Hello everybody, and welcome back to the third video in a series of videos for Exam 1 for PPI. I do want to preface this video by saying that while I believe the other two videos stand up very well in this series, this one's a little bit harder for me to teach to. Uh, this is Dr. Weber's content, and his questions are notoriously pretty difficult in the sense that he does teach you everything you need to know in class, but he gets into very specific details where I feel like a lot of the other instructors for this first exam of the course have been more generalized, and that has given me the ability to make more generalized videos on them. I have tried to incorporate what I remember we were assessed on into the slides, but I really do not remember everything, to tell you the truth. And obviously questions will change from year to year as well. So I can't guarantee that this video will be as useful as the other two were. Is also for that reason I don't really plan on covering exam 2 on this channel. I will be covering exam 3 and part of exam 4, but I believe exam 4 suffers from the same problem where some of the content just gets too specific. So I'll cover, that'll be your immunology exam. I'll cover the general and the basic in that, and maybe some of the more complex stuff. But as for exam 2, I really don't plan on covering it right now. That's split between Dr. Weber and Dr. Weigel. It's also not the hardest content in the world, exam 2. It's just patient-specific medication factors, which are definitely doable. It's just I don't want to cover every single specific in that video because essentially those specifics will already be covered in the videos they show. It'll be in detail there, and it's basically that exam is more memorization than application. Whereas with something like dose response, for example, you have a much more complex problem where you actually have to like apply your own knowledge and problem solving skills versus just blatant memorization. But with that, I did want to cover in this video because I believe these topics are pretty important. So I'll give some of the general and some of what I remember was tested on for us. But yeah, with that out of the way, let's hop into it. Okay, so how are drugs designed? So modern drugs typically are designed to look like a substrate or to match an enzyme. So we have an example right here. Folate is super similar, folate being just a nutrient in our body, to methotrexate because methotrexate mimics folate to bind an enzyme that metabolizes. So with methotrexate, we're essentially trying to increase our concentrations of folate by blocking the enzyme that would normally like destroy it with methotrexate. Um, Something else, ways we can design drugs, these are more biologic-based drugs. So small molecules are typically your drugs like your statins, your high blood pressure medications. Biologics are another class of drugs. They're typically protein. They're a lot bigger. They interact differently in the sense that they can't really penetrate cell membranes. The fact that they may cause an immune response potentially, or at least more likely to than a small molecule, just being a few of the factors that separate them. But anyways, what we can do is we can actually essentially farm these. And the way we can do it is by creating custom DNA, or the DNA we want, putting that into genetic material, and then introducing that into a vessel like E. coli. And then E. coli will produce that protein for us if we have a way to upregulate its system to transcribe that gene, which scientists have mapped out, and there are ways we can do that. There's a few different models we can do this in. It's not just E. coli. Um, E. coli and B. subtilis. Some of the upsides and downsides to these, I'll just go through them really quick. This is about as in depth if you need to know these. You might get one question about upsides and downsides of vessels on your test. Um, these two are fast and cheap. They're prokaryotic. And the problem is they're really simple. They don't have what's called post-translational modification. You'll learn more about that in MMP, but basically after a protein's made, in eukaryotes, things like humans, complex organisms, will kind of add some things onto those proteins, make them a little more specialized. E. coli and B. subtilis can't do this. Yeast is fast. It's also eukaryotic, so it's a little more complex. But the problem is there's certain substances you can't add, like sialic acid and just other things in their growth medium. So if that's required for the creation of the protein or the process, yeast can be a little limited then. Next up, we have baculovirus. So this is a safe, since it's a virus, it's not a prokaryote or a eukaryote. It's kind of its own thing. What it does is it infects the cells of insects. And it's non-toxic to human because it's only specialized for insects. So that's a really big plus, whereas like E. coli can obviously make people pretty sick. Um, The only downside is there is some lower yield. Since we're doing this in an insect inside of an animal, we can't always regulate all the processes, so the yield's going to be lower than something like E. coli, which is just pumping out the protein you want. Um, the last two are probably the best in terms of complexity of protein, and just how much we can specialize and potentially how safe it is. Introducing genes into mammals or into plants and animals. The only downside is it obviously takes a very long time to make a plant or animal grow to its max size, and that can also be very expensive because you need to feed it, you need to care for it. It can take a lot longer. Now I'll talk about, I mentioned biologics before. Biologics, again, being like the protein class of drugs. Group 1 biologics are enzymes and regulatory proteins. Think like your insulin, hormones, things of that nature. Group 2 are targeted proteins. For this, you might have what are called monoclonal antibodies. We'll talk a bit about that during this class, but that's essentially an antibody that we've designed to target a certain target synthetically, to like cure disease. And a really common use for those are in things like arthritis and usually more complex diseases. For something like blood pressure, we won't really ever need a monoclonal antibody because it's so simple to reverse. But from some of those like more complex diseases, this is what we usually try and use them in. Group 3 is protein vaccines. If you had to remember one of these, I'd remember Hep B. I don't remember if that was a question or not. That might come up again later. That's like your most common protein vaccine. You'll learn about that a bit when you do your vaccine training in the spring. And then finally, group 4 is protein diagnostics. Think like test, like HIV test. I think you can also do like Hep C. So things of that nature. So this is just testing. So really the two that you might think of as traditional drugs are probably groups 1 and 2 because these are something you'll either ingest or have injected, where like vaccines and testing, while they are drugs, they're not really drugs in the sense that you might typically think. I guess vaccines maybe, but definitely like 1 and 2 are traditionally your more either injection or tablets or however they're administered. So, like I mentioned before, monoclonal antibodies are really useful at targeting specific diseases. But the problem is we can't use human models for research, right? Like making a human vector to create our protein like therapeutics, especially antibodies, it's like we can't just have a person making those. It's super unethical. So what do we do about that? Well, we originally started with murine antibodies or mouse. Murine means mouse. You might see that on your exam, so just so you know. But there's a problem. When we introduce proteins from another organism, especially complex proteins, our immune system freaks out. It thinks we have an invader, like bacteria or something, or just some foreign invader that's not supposed to be there. Because in a way, it sort of is. It's just we know it's supposed to be helpful. Our body doesn't. So what do we do about that? Well, we began to combine these human and mouse antibodies together into what are called chimeric antibodies. So this short chain of the antibody is the sense that actually, or the part that actually kind of codes for what the antibody does, what it'll bind to. And this heavy chain is just more of like a neutral region that doesn't matter as much. So what we'll do is we began to combine mouse heads. So the mouse are the ones that we can like modify and research, but attach them to the human body. So what this does is this will create something that won't be as likely to react. However, this still isn't perfect. With these CDR grafted antibodies, we've actually gotten select parts of the mouse antibody that will bind selectively like how we want it, but we minimize the amount that it's there as much as possible to like minimize reactions. With any monoclonal antibody, you still have a chance of an adverse reaction. With these CDR grafted and these hybrid, these chimerics that combine human and mouse or human and whatever, usually mouse though, you're much more likely to be safe. Um, so yeah, just remember that the light chain and is the one that actually codes as well. That might be a question. Um, what else? What else? Oh, a little bit of nomenclature. You don't need to know this whole chart. I wanted to throw it in here though. The ones that you should remember are Z as in XI, mean chimeric, as in that hybrid antibody, this one over here, that's a combination of mouse and human. Whereas ZOO means humanized. Now, this can have a lot of definitions. It means that it's at least partly human. So that could honestly be any one of these besides just our murine antibody. It'll usually be referring to either CDR or chimeric, but just put that out there. And MAB means monoclonal antibody. So if you ever see that, that'll almost certainly be a question. I do remember that, and Dr. Weber does have a terminology question. I know that. It's really just going to be from this list of these. He'll have for us it was this really complex cancer antibody. Like if you wanted to, you could go through and memorize these tumors, but or just diseases. A lot of them are usually tumors, because we use a lot of monoclonal antibodies and anti-cancer drugs. But honestly, it's just the ending that he's really testing you on, because he'll usually be like, oh, it's this type of tumor, but like, is this a chimeric antibody? Is this a humanized antibody? What is this? So that's what I look for. A couple of examples of monoclonal antibodies. We have etanercept. This will bind what's called TNF alpha. This is an inflammatory mediator. You'll learn a little bit more about this later in this course and also later in course. And what this does is this is a dimer. If you remember in our last video, we talked about tyrosine kinases. What this does actually is these are two separate proteins, but when TNF alpha comes, it'll actually bind and it'll link these together and kind of like trap it like a cage inside the blood. Um, and the way I remember that one is etanercept kind of sounds like intercept, because it intercepts TNF alpha in the blood. So that's how I memorized that one. That's just my little mnemonic that I've used. Anakinra attacks what's called IL-1. It actually attacks the receptor uh, instead of IL-1 itself. So while etanercept attacks the mediator, uh, anakinra will actually attack the receptor. Because you have to stop one or the other, right? If you stop the molecule, the signaling is going to stop. If you stop the receptor, the signaling is going to stop. IL-1 is another inflammatory mediator, so by blocking its receptor, by attacking it, an IL-1 receptor antagonist, um, it will essentially block that action. So anakinra attacks receptor, and etanercept attacks molecule. If you can remember that, I think you should be good on these two. There's definitely a question about one of these. I think ours was etanercept, but I really do not remember. So just know those two vaguely to the extent I described, and you'll probably be fine. There are various types of cancer treatment methods, as well as different causes of cancer. So I'll go through kind of how we've gone about designing drug mechanisms to attack certain types of cancer. So over here, we have essentially things that can cause um, cancer. So we have antigens from, or genes from viruses. Eventually, there are certain viruses that they insert genetic information into your cells in just the right way. They can actually cause cancer. Just mutations in general can cause that. Translocation of what are called proto-oncogenes. These are like genes that are potentially cancerous but are kind of turned off until they get in the right place. Our cells automatically have these. They're not meant to cause us cancer, obviously. If they're just in the wrong place at the wrong time, that can cause us cancer. Other things that can cause cancer are alternative transcripts and post-translational modifications. If you remember from biology, transcription, translation, basically alternative transcripts means there is something wrong with the proteins we're producing. And post-translational modification means that we're adding something onto a protein we've just transcribed incorrectly. That's upregulating cancer. Um, Anti-cancer genes might be silenced, meaning they're not expressed. We have certain mechanisms in the body that can prevent cancer, and if those are silenced, we have a less chance of protecting cancer. And then there's idiotypes, which basically just means we don't know what's causing the cancer. It could really be a factor of things. It could be something we still don't even know about. Cancer is a very complex disease because it has a lot of causes, and you have to treat everyone very differently. So let's talk about Gleevec. You'll learn a bit more about Gleevec, which I believe is imatinib in MMP. I do have a video on it. I believe in my MMP exam 3 unit, if you really wanted to learn more about it. But for the purpose of this class, Gleevec will prevent cells from over-proliferating, and the way it does this is in this specific type of cancer, um, you'll have this mechanism that'll always make it be turned on, essentially. And what this mechanism regulates is it's if the cell will divide or not. So as you know, cancer cell tumor, irregular growth, if the growth mechanism's always on, then the cell won't be able to stop multiplying. It'll be cancerous. However, what Gleevec can do is it can actually block this site that would be turned on. And with that, Gleevec is actually able to stop the cancer from over multiplying, which is really good. It's very beneficial. There's a lot of cancer treatments that work similar to that. Um, Gefitinib is another one. This prevents endothelial growth factors from causing overproliferation again. Um, Again, the mechanism of that isn't super important, but as you can see here, I believe this is, yeah, cell viability of the cancer goes down as gefitinib is administered. Another thing you can tackle when treating cancer isn't just the proliferation of the cells, but cancer possesses this thing called high angiogenesis. And what this word means is this means high reproduction of blood vessels. So why is that important? Since blood carries all our nutrients to all our cells, cancer really likes upregulating blood cells and blood vessels around it in order to essentially fuel itself, fuel the tumor and make it be able to grow and be viable. Almost think of cancer as an organism that's trying to compete with your body in a similar way to like a bacteria or a virus would, just on a much larger scale and also using your own cells. Granted, the vessels created by angiogenesis are usually a lot more irregular. They're not as well formed. Um, so there's different drugs that can actually prevent angiogenesis. There's this one you'll learn a bit later in a video I'll have coming up on posterior eye diseases. I believe this one occurs in macular degeneration. We have this drug called Avastin, which again is usually used for macular degeneration. It is an antibody. You can see that monoclonal antibody, also humanized with that zoo. Just get in the habit of looking at that and seeing if you can like decipher what those mean. Um, but this will target a factor called VEGF, and this is vascular endothelial growth factor. I believe that's what it stands for. But anyways, by blocking this, vascular, the first part in its name, you're essentially blocking those veins from being created, those blood vessels. So this disease that not only works for a different type of disease, also works for cancer. So as you can see, a lot of different types of cancers, a lot of different ways we can fight them. Um, if you were asked something on this slide, it'd probably be Gleevec, because I believe that it comes up again with another example of Gleevec a little later in this course. Um, but yeah, just be aware of that. Know that cancer is super complex, and it's basically the way we stop cancer is by trying to stop it growing, whether that be directly or from the factors that can help it grow. Now let's talk a little bit about patient populations. I know I said I wasn't going to do exam 2 stuff, and I remember when I was going through these slides, I was a bit surprised that this was honestly included, because this is essentially what you need to know at a very baseline level for exam 2. We're talking very baseline. Don't make this slide your entire study session. But these concepts are basically just what you branch off of. So I'll go through these really quick, just so there's at least something for exam 2. I hope I can help with that. So let's talk geriatric population, so older people. The way they are physiologically different from someone who's younger is they make less proteins, which if you remember from our first videos, those proteins like albumin, which bind drugs, make lower drug effects because the drugs are bound to the proteins, they're not able to act. And there's also factors with half-life. This is a little less important. But assuming those drugs are bound less, that means older people might be more sensitive to drugs if they're not being bound as much. Older people also have lower digestive function and metabolic function, meaning that if something passes through your GI tract slowly, remember, it's going to get absorbed more before it gets excreted. As well as that, if they have less metabolism, there's going to be higher drug concentrations. So in older populations, we might actually dose them lower just based on what diseases they have. Um, as well as this, they have increased drug sensitivity to certain classes. Um, Beta blockers, antihypertensives. This is really important because a lot of older people have things like hypertension. They have things like hyperlipidemia, high cholesterol. Um, and they're on the most medications statistically. So being aware that these people are not only more sensitive to medications, but also the doses we might give to a middle-aged adult might actually be too much for them. It's something to definitely be aware of, especially if you're in like a clinical position where you're helping decide the dose. A little bit less so in community, but still, just if you see something weird, definitely keep an eye out for it. Pediatric patrons, children, may have less or different proteins. The biggest one is probably enzymes in your liver, your CYP450 or CYP450 system. Super common because that obviously metabolizes most of our drugs. But even something like hemoglobin is another example of a protein that changes. A little less drug related, but um, infants have a different type of hemoglobin than adults do, which actually carries oxygen better. So being aware of that, if cells are receiving more oxygen, maybe that factors into a drug. So being aware of things of that nature. Again, they have different drug sensitivities too. Sometimes they're more sensitive, sometimes they're less sensitive. They have different hormone balances, which also means different gene expression. We talked about that a little bit last video. Different organ functions. And also the biggest one probably is different ratios of water to fat. And you might hear a lot in pharmacy school that infants are kind of like bags of water because they really don't have a lot of fat. I mean, we see baby fat on babies, right? But just by size, the mass of an infant is much more composed of water. I think it's like if a human adult is like 70% water, I think an infant is like 90% water. Um, so obviously a bit of a change there, especially for if you have a hydrophilic drug, or even a lipophilic drug. It really depends where it's absorbing, but just to be aware of that. Um, Another thing is um, differences between men and women. Hormone cycles in both men and women can alter the function of drugs. One thing especially that you might actually see a question on. I don't know if we saw it on this exam. I think you definitely see it on your next exam though, so definitely make a note of this. Is Women have a longer on average, what's called a QTC interval. This is essentially has to do with the rhythm of your heart, but having a longer QTC interval can actually make you more susceptible for something like a heart attack. So it's really essential, especially in women, to if you have a bunch of drugs that raise their QTC interval, to monitor them because they are more at risk. So especially cardiac drugs, you can see like drugs that also affect PGP. Uh, Something like digoxin, which is like an arrhythmia drug, can also, I believe it's an inhibitor of PGP. It's either an inhibitor or inducer. It doesn't really matter, but just be aware that whenever a drug like that does interact with a protein, um, it can change the response and it could send it too far one way or too far the other. So we really want to be watching those. Um, Environmental effects, smoking. Um, Probably pretty obvious at this point. Smoking can cause all sorts of diseases, cancer, lung disease, etc. Alcohol can also raise chances for cancers, but especially the big thing with alcohol and drugs is since alcohol damages your liver, especially with abuse and overuse, that ultimately leads to our CYP enzymes, our metabolism enzyme. So drug effects may be way higher in people with like liver diseases from alcohol. Diet affects metabolism as well. Um, Also, another thing is metabolism changes with genetic variation. Kind of a no duh. That's pretty much what pharmacogenetics is, and pretty much all of it your third exam on MMP will be. Just something to remember. Something else is infectious disease states in our body. If we are sick, we will metabolize things differently because some parts of our body might be fighting an infection, or there might even be bacteria in our body that can metabolize our drugs, which would be good and bad. If it's like a prodrug and we need more of it, the bacteria could actually break that down for us. But in most cases, let's be honest, it will most likely be either a toxic metabolite or it will inactivate a drug, which is obviously not good. So definitely, even when people are sick, their drugs are going to affect them differently. Or even from the sense that, let's say it's the stomach bacteria. If the bacteria makes the environment more basic, if the drug needs to be absorbed in an acidic condition, like we talked about in our first video, it won't be able to do that as well. Um, Now let's talk about child Pew and creatinine clearance. So child Pew score is essentially a score of liver disease. There's a whole table right here that you won't really need to memorize unless they change that. I definitely listened, but I don't think they're going to have you memorize it. They'll probably give it to you on the test, but I think you will need to calculate a child Pew, if not on this exam, on the next exam, where you learn a little bit more about liver and kidney disease. Um, and essentially, you want lower score ideally, and this just shows you liver function overall. Similar to this, there's also kidney function, um, and you have your, I believe it's the Cockcroft-Gault equation, or creatinine clearance equation, um, which essentially will measure what our kidney function is. And we do have an equation where we can estimate this, or at least creatinine clearance. Um, And this is 140 minus age times weight in kilograms times 72 over serum creatinine. Serum creatinine will always be given to you in the problem, but you will need to memorize this equation. 140 minus age and weight in kilograms. So definitely write this one down, commit this one to memory, because you'll be seeing this all the time in pharmacy school. Something especially that's been happening is, I don't know if you've been told already, our NAPLEX scores recently have been really bad at math. Uh, and that's a little bit hard to remedy because other than pharmacy calculations, there's not a lot of places you can insert math into a lot of the curriculum we do, but they're still trying to. So the way they've been doing that a lot is actually just by putting kidney functions in the problems to make sure we've memorized the serum creatinine equation. So if you can memorize this and commit this to memory, this could actually be really easy points overall because nobody else knows what to make a math question out of. So something to be aware of there. Also, something else that's huge, and even I forget this sometimes. Um, for male patients, this is the base Cockcroft-Gault equation, a creatinine clearance equation. But for female patients, it's the same thing, but you need to multiply by this factor of 0.85. Um, you'll never be told to do that. I mean, you'll be told if it's a female patient, but the problem won't mention that. Like, make sure to include this multiplier. Like, no, that's something you need to have to memory, and you need to always be checking for it. Otherwise, you just get the problem wrong, especially because I know in calculations, there's no partial credit. So definitely commit that to memory. And I think you do get this equation in calculations as well eventually. Probably not until the last half of the course, though, I would assume. Now let's go into drug resistance. So there's a lot of factors which can cause drug resistance. Um, the two big ones that I want to start with are efflux and uptake. Efflux essentially means shooting something out of a cell, exporting it, and uptake obviously means bringing into a cell. Um, and these are done by channels, obviously. Yeah, assuming it's like, unless it's like a lipophilic steroid or something, which can cross the membrane on its own without a receptor, which most drugs aren't. It'll need a channel. So how are these do? Well, or how does this happen? So there are gated channels. A really common way for this to happen are with what are called ligands, which I believe I've mentioned briefly in a video before. Very common one is acetylcholine, ACH. And these can open or close channels, kind of just depending. But this is probably your most common signaling molecule to open channels, which can either allow things to be brought into the cell or pass out of the cell. Um, As well as this, ligand channels like acetylcholine channels can also have different types. So you have your uniporter, this will move one substance one way. You have your symporter, this will bring more than one substance the same direction. You have your antiporter, this will bring at least two substances moving in the opposite direction wherever they need to go. Then there are also channels. These are typically open, but these can be gated with something like a ligand. Um, That's something else to note. These transporters are not channels, but they can be gated with something like acetylcholine. They can have like a co-activator to activate them. I just want to make sure I made that clear. This one's the only actual channel, whereas these are kind of proteins that'll like meld their shape or move across the membrane in order to bring them into a cell. Um, Now for different types of transporters. So you have your ABC transporters. That stands for ATP binding cassette, ATP being our major energy molecule in our body. There's three families of this. There's our MDR1s, our MRPs, and our MXRs. You can see this is ABCB1. These are almost always efflux, and they all require ATP. They shoot things out of the cells. Something else that are transporters is we also have our oct transporters. These are cation transporters. That's what the C in oct means. I believe it's organic cation transporter. These are OATs. These are anions. And these will typically be efflux as well. These vary a little bit more, whereas ABC will always be efflux. Then we have our ENTs and our CNTs. These will transfer nucleotides. So think like adenosine, guanine, cytosine. Essentially just our genetic building blocks that we need in places like our nucleus. Like we obviously need to bring these things to our cells so they can reproduce or they can build their DNA, build their RNA, whatever they need to do to code for their proteins. And then the proteins themselves are made of amino acids. So just so you know, that won't be in too in-depth. I remember really studying these, like trying to memorize the specific transporters and like where they worked in the body. That's really beyond the scope of this course. You won't get tested on that in this exam unless they're really mean, but I would not waste your time studying that. There are specialized barriers that exist in some parts of our bodies that will lack a lot of transporters, or at least they'll have a lot of efflux transporters in conjunction with few influx transporters, just because we need these sites to be protected. These are called privileged sites. So pretty obvious one, blood-brain barrier. Sure, you've all heard about it at this point. We can't have all our drugs getting into our brain, right? We try and protect our brain because it's essentially the control center for all the processes in our body. We need it to stay alive, and obviously there's some drugs that can pass through, like psychiatric medications. These are usually very small. They usually do not have a charge. Those are two of the biggest criteria for them being able to get in, but even then, it's very selective. Two you might not have heard about as much, but kind of make sense when you think about it, are the blood-testes brain barrier, or not brain barrier, and the placental barrier. Kind of makes sense. Um, all the reproductive information of a man, as well as a mother growing a baby in the uterus. We don't want drugs getting to that fetus, that unborn baby. Um, it kind of makes sense. So it's like protecting our brains, but also protecting kind of our reproductive sites in order to not affect those processes. So another thing is drugs can be inactivated by different enzymes. And actually, it's not just our own enzymes, but bacteria can actually introduce and metabolize certain antibiotics to inactivate them if they evolve resistant. You've probably heard about MRSA, multi-strain resistant Streptococcus aureus, I think. I think I did that right. I'm not an infectious disease expert. But anyways, what that'll do is that'll inactivate our antibiotics. And that's how it's essentially evolved resistance against these. And that's by adding on groups usually. Through enzymes, so you can add on acyl groups, phosphoryl groups, thiol. It doesn't really matter. What really matters more than anything is that it's adding on a group that would act on the enzyme that would kill it. And that can happen sometimes. Um, Another thing that can happen is for resistance is mutations can occur in the gene targets. You may remember Gleevec. I talked about it a couple slides ago, how it's a really good drug. It is. Unfortunately, it only works for about 18 months. Remember when I said that cancer was kind of like an organism our body is fighting against? It, like our own bodies, can adapt and reproduce and naturally select against our cancers or our treatments. And a drug like Gleevec only works about 18 months if it doesn't totally eradicate the cancer when it's on its first go through, which is not ideal. I mean, a year and a half, right? But if you can't get all of that cancer, statistically, it is likely to adapt around it, which is very bad because Gleevec is such a good drug um, with pretty few side effects for chemotherapy medication, all things considered, um, that it definitely makes treatment a lot harder to not have that in our repertoire. Um, Drug action can also be reversed as a means of building resistance. Um, I mentioned the pathogens destroying antibiotics like our MRSA. Um, and also we have things any toxic substance we introduce can also be detoxified. You may remember this was probably in an MMP video as opposed to a PPI video. Our glutathione system, essentially our system that detoxifies super radicals, we have it in our body. Bacteria also have it to a lesser extent. So some of our methods in antibiotics are actually by creating these super reactive, super toxic species of molecules that can destroy the bacteria. However, they may have systems that have adapted to kind of quell those reactive molecules, kind of like we have. Not to the same complexity, but just same idea. Um, Another term I want you to be aware of is desensitization. This occurs when either the number of receptors decreases. So think about it. Decreased receptors means decreased overall response because there's not enough signal. Either that or the drug response lowers. Just for some reason, the receptors become less affected by the drug, or the response sent out is less effective, even if the numbers are the same. Which can occur for various reasons, but that's kind of beyond the scope of this course. So just be aware that it can happen. So now the definition of tolerance. Tolerance can be pharmacokinetic in the sense that if a drug is metabolized or excreted more quickly, um, the body won't be able to adapt to it as much. So this is almost like, as we talked about a second ago with desensitization, there are less receptors. This has to do with metabolism. So if there's less receptors or more enzymes that are breaking down our drugs, you can build a tolerance. And that can happen pretty naturally in the body. If you have a lot of a foreign chemical and our body knows it needs to be metabolized a lot, you're probably going to build up a tolerance over time, so your body can deal with it more. Um, or tolerance can also be pharmacodynamic, where the receptor itself actually changes. This could be a genetic change, this could be a shape change. This is more similar to like the loss of sensitivity of receptors, which occurs with desensitization, but that can also be caused by tolerance. Another term is cross tolerance. Cross tolerance is when you have tolerance to a drug in the same class as a drug you've already received tolerance to. So let's say you abuse a certain type of opioid, um, and then you are admitted to the hospital for one reason or another for pain, and they try and give you morphine. That morphine, which is also an opioid, may not be able to help you as much because you've gained such a tolerance to abusing these opioids. And if you don't tell your healthcare providers that, the morphine might not do much, and that can be a serious problem if you're especially in pain. Um, Something else about tolerance is I mentioned that tolerance is like a lack of sensitivity. Tolerance can actually be overcome by doing more of a drug. That's probably why you've heard the term tolerance before in the case of like talking about addiction and things of that nature. Addicts will tend to do more because they'll have a tolerance that they want to overcome. So they take higher and higher doses. It's just unfortunate that those higher doses can also lead to death and some especially illicit drugs such as like heroin. Um, Dependence is another term that you need to know. Dependence is the physiological need to take a drug, so not just psychological, but physiological. That's a huge sticking point. Without this drug, your body can now not complete its normal functions. Your body physically needs these drugs. And withdrawal can actually have adverse effects, which can lead to death potentially if you don't wean off, especially if you're addicted to things like heroin, fentanyl, these crazy high level narcotics. Um, that your body physically needs to function because they alter all sorts of things like blood rate or blood pressure, cognition, heart rate, all these things. If you suddenly stop, you can have all sorts of like rebound heart effects or psychological effects, which can be really dangerous. So that's why addiction to drugs is like especially dangerous. Just for the senses that physically stopping can be even more deadly than potentially taking the drug. So when you're looking to get off of a substance, you should definitely consult a healthcare provider to see what the best course of action is to do it. Side effects. Side effects are any effect that the drug can have, other than the main effect that's advertised. So like obviously an antihypertensive medication, it's meant to lower your blood pressure, but let's say it also, I don't know, let's say it has an antidepressant effect. I think like propranolol with that. That's a good example. Propranolol is usually used for hypertension, but it can also be used in adults. Usually helps with like stage fright. The reason that kind of happens is because it's meant to lower your heart rate, but if our heart rate's lower, that has less anxiety purposes. That's a side effect, sort of. It depends on what the propranolol is described for. If it's only prescribed for hypertension, um, for high blood pressure and you get that anti-anxiety effect, that's a side effect. But if your doctor prescribes it for both anxiety and for like blood pressure, then it's not a side effect. Side effect just means it's something other than we intended the drug to work for. And again, they could be positive, like those anti-anxiety effects, but they can also be neutral or negative. Um, as far as prevalency of adverse effects, 10% of adverse effects are allergic reactions, and 3% of reported adverse effects are life-threatening or fatal. Take this with a grain of salt, just in the sense that these are reported adverse effects. If you have a more severe reaction, you're obviously more likely to report a drug. So that doesn't mean that 10% of people have allergic reactions and 3% of people have life-threatening reactions. That means those are the numbers that are reported. And those aren't numbers you necessarily need to know, but you should be aware of kind of the differences in these types of effects. And then for the most part, people just report normal effects, like 85% of the time. Well, not normal, but not deadly. Um, Idiosyncrasy is a term used to define anything that's unexpected to the real result. And a key thing about idiosyncrasy is that it is replicatable, meaning you can do it more than one, or reproducible, and it's also reversible by an antagonist or an inverse agonist, which is really rare. This term is misused a lot. because it could be a random side effect, but that doesn't necessarily mean it's an idiosyncrasy. And the fact that if it was only a one-time thing, or it's not actually reversed by an inverse agonist or an antagonist, meaning that it has a different drug mechanism, it's not really unknown. It's just something different. Um, Now moving on to what an allergy is. Um, Allergies are essentially drug effects which elicit an immune response. Um, to have a true allergy, it would never be the first time taking a drug. It would always be the second or further. You'll learn more about this in the immunology section of this course. But essentially, the first time your body has a drug, the immune system will detect it, it'll attack it, and so on, get it in your memory cells. Then that second time you have that substance, your body will launch an attack because your body basically thinks that there's like a foreign invader, a bacteria, a virus, or something, and it thinks that drug is. And a way to treat allergies is with immunosuppressants, but there's also other factors. So immunosuppressants like prednisone, super common corticosteroid. One you probably know, epinephrine, that's an EpiPen, as well as antihistamines. Think your diphenhydramine. This is like your second line for anaphylactic shock if you don't have epinephrine on hand. Most pharmacies will carry both just in case somebody has an allergic reaction. Something to be aware of. And there's other classes like leukotrienes. This is more for like allergic asthma, but still something you might see later. Um, Anaphylaxis, then, I know I just used that word without defining it. It is essentially a life-threatening allergic reaction. Um, yeah, that's pretty much what it is. It's a life-threatening allergic reaction. Common things, you might feel your throat closing up, things of that nature, you might pass out, like all sorts of things. And that's when you really need your epinephrine or your diphenhydramine. Um, but the most important thing, which I swear this was a question on either this exam or the next exam, the most important thing to do if you have an allergy is to discontinue the offending agent more than anything. Please remember that. Because obviously, if somebody's having an allergic reaction to something, we can pinpoint what it is, you need to discontinue it, especially if it's serious. You can make the argument if it's a very mild reaction and the drug has so much more benefit. Again, it really depends. Like, it has to be like a life-saving drug, though. It'd have to be like a chemotherapy drug in order to justify that. And that would really take clinical judgment, and it probably wouldn't be something that a pharmacist would be put in charge of. That'd probably be up to the prescriber, quite frankly. But yeah. So just discontinue something if it's making someone allergic. The final section I want to talk about is teratogenesis. This is essentially birth defects. That's what that word means. Uh, and it's an effect caused by some kind of external event or substance that is not inheritable. It's not a genetic change that happened. It's we introduced a substance and something went wrong. The most common case of this in history is probably thalidomide. I'll write that down. Thalidomide was an anti-nausea treatment that was used in, I believe, the 60s, late 50s, early 60s, for morning sickness for pregnant women. But unfortunately, one isomer of this drug, one form of it, actually caused really toxic side effects to the unborn infant. They would come out, they'd have very small, deformed limbs to where they weren't able to do things. And this actually made a bunch of drug legislation passed in the United States. It was the Pfeiffer-Harris amendment, and I think that was 1962, which proved drugs they had to go through efficacy and safety trials. Um, and one of the things of that is we now need data on all our drugs. So dangerous drugs during pregnancy, or all drugs really, are rated by what it's called PLLR, safety. This was on your slides in class when I went back to look. This ABCDX category, you might see this more in pharmacy school. They actually stopped doing this in 2014. There's a newer system now, so I included it on this slide. It's the only thing on this slideshow that's been in color, so that's probably sticks out a little bit. But essentially, there are three new categories. We have a category for pregnancy, lactation, and reproductive health in both males and females. So again, it's not just pregnancy now, but also looking at if you're lactating, is this drug dangerous? Will this drug make you infertile? Things like that. So very good system overall. Glad they amended that a little bit because ABDX wasn't quite covering it. Um, Drugs can interact with other drugs to cause toxicity. Really vulnerable populations to this are the elderly. They have a lot of polypharmacy, meaning taking multiple drugs at once, as well as the chronically ill. People, especially, again, I keep using the example of cancer chemotherapy, but it's a really good one because you're on so many drugs and your body is so weak at that point. Because these chemotherapy drugs are weakening your body, you are much more susceptible to reactions. Um, Drugs can also up and down regulate our CYP enzymes. There's a couple ways they can do this. Drugs can up and down regulate their expression. So certain drugs may increase expression of CYP enzymes. So let's say a drug genetically makes more CYP enzymes in one way or another that metabolizes another drug, will have less of that drug's effect. And vice versa. If we have a drug that makes that enzyme express less, we'll have more of the drug that would normally be metabolized by it. Um, Another way this can happen is just simple, irreversible inhibition, non-competitive inhibition. An active site could just be bound by one drug that prevents another drug from being metabolized, and that can lead to that drug being in really high concentrations and having a higher effect. Alternatively, I didn't even bring this in until now. You could also have like a prodrug, which basically just flips everything I just said. But just know some drugs need to be metabolized in order to be active, and some need to be metabolized in order to stop being active. So changes in those enzymes are kind of going to be what determines that. Um, and it's not just drugs either. There are other substances which can affect drug metabolism. The biggest one you're going to see throughout pharmacy is grapefruit juice. This is a CYP3A4 inhibitor. Uh, you might get a question on this, actually. I think it's on the next exam, though, not this one, but just something to be aware of. An alt-rate inhibitor. It's kind of funny that just a random type of juice can inhibit the most prevalent metabolizing enzyme in our body for drugs, but also a little bit concerning. I don't think there's anybody I've ever met that really drinks grapefruit juice, but in case they did, they could be at risk for their drugs not being metabolized and having some over concentrations of drugs that which could lead to some toxicities. So definitely, it's a weird question to ask, but if you know somebody that drinks a lot of grapefruit juice and they also take a lot of drugs, maybe talk to them about that because there's a chance it interacts with their CYP3A4. Final thing is, which can cause adverse effects of drugs, is medication dispensing errors. All sorts of things. Packaging is wrong. Um, Words on the packaging are too complex. Failure of equipment. Handwriting from a prescriber. I'm sure those of you that work in community know that. Labeling errors, excessive workload, medication unavailable. You're never going to get a question like this that's going to try and trick you. If it gives like a bunch that sound right and then it says all of the above, it's probably right. Or if it's something that sounds like, if it's four answers that sound completely made up and then one that sounds logical, it's like, oh, the labeling broke versus like the pill fell on the floor and they just decided to give it anyways. Just pick what sounds logical for those if you ever get them on an exam. But just know that with adverse like effects like or errors in dispensing like this can cause serious consequences, right? Because any one of these steps being missed can lead to a patient getting the wrong drug, and that can obviously potentially lead to toxicity or death. So it is a very serious subject. Um, that definitely needs to be monitored. But as far as test questions go, it's pretty common sense, especially to those of you that have probably worked in community pharmacy and other aspects of pharmacy at this point. But with that, thank you so much for sticking with me to the end, and good luck on exam 1.